The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this holiday season to be hosting our good friend Tim Bahr, who is making a lot of things a lot clearer to me about alloimmunization. Welcome back, Tim.
Thanks, Paul. It's great to be here. And thanks for keeping our holiday tradition.
Exactly. Well, hang out the stockings and talk to Tim about blood stuff.
That's right.
All right. Do you want to talk about your disclosure again?
Yeah. Our research program at Intermountain Health receives research funding from Johnson & Johnson for our phase 3 clinical trial of a drug called nipocalimab that's under development. And so I don't receive any extra compensation than my salary, but certainly Johnson & Johnson is providing financial support for that study.
Sure. Well, the past couple of weeks, we've talked about the pathophysiology of hemolytic disease of the fetus and newborn. And we've talked about the workup, both prenatally and after a baby's born. This week, we want to talk about management, because management makes a huge difference. And is part of the reason why it's so important for us to understand this, because we can make a big difference.
Absolutely. Yep. I would say alloimmunization and hemolytic disease of the fetus and newborn is, just like many things in pediatrics, prevention and preparation make a huge difference in the outcomes.
All right. So now we have an infant with hemolytic disease. And the issue number one is we hope this infant is now in the right place to get the treatment that they need. Let's talk about the immediate management of these babies. First of all, how do you deal with the immune hydrops?
Yeah. I think, Paul, in that case, we would need to have a neonatologist, a NICU ready. If for some reason, if we're not aware of hydrops that has developed, we perform NRP. If it's immune hydrops, that baby's going to need blood. They're going to need red blood cells as quickly as possible. And then we treat hydrops, just like everything in NRP and in pediatric medicine, airway and breathing comes first, and then circulation also. When I've cared for babies with immune hydrops or non-immune hydrops, we secure an airway, make sure that they can breathe. Generally, oftentimes those babies will be intubated and ventilated. And then from there, sometimes to help them ventilate, the definition of hydrops, which we talked about in previous episode, is fluid in 2 or more compartments of the body. Sometimes that's pleural fluid around the lungs or ascites, both of which can compromise, or it can be pericardial. So in the case of pleural or abdominal or ascites, that can compromise the infant's ability to ventilate. And so those babies, we will tap those fluid accumulations with a needle and sometimes with chest tubes if necessary. And then if a pericardial tap is necessary, we can do that too. So hydrops, if you have a baby that's delivered that's hydrops, they definitely need NICU level care immediately. And hopefully the NICU is already there to help out. And then certainly during the resuscitation period, even if I don't know, I would say when I have to unfortunately code a baby in the delivery room or in the resuscitation room, I am quick to administer blood, even though I am a good transfusion steward. If that baby needs resuscitation, volume resuscitation, and I have any doubt that they might be anemic, and especially in the case of hydrops, I'll order emergency blood immediately, red blood cells, fresh frozen plasma, and then maybe platelets thereafter.
Keeping in mind that this is a baby who, as a fetus, whose blood has been treated as a pathogen by antibodies. And so this process is well underway at the time of delivery. So this is really, in some ways, your first chance to intervene. So the timeliness is huge.
Yep, absolutely. And so part of our recommendations, sort of the maternal recommendations, are when you have a alloimmunized mother who is alloimmunized to a red blood cell antigen, we actually prepare before that baby is born. The hospital who's going to deliver that infant, that baby, needs to have blood that's been cross-matched to the mother on hand. The reasons for that, one is for the mother, if she hemorrhages. The other one is I can use that for the baby too. And
Sure.
so So it's a little complicated. I would say unknown hydrops is rough. Unknown immune hydrops is rough, but that's why preparation is so important.
What about severe hyperbilirubinemia? How do you treat that?
Yeah. Generally speaking, I would say the treatment thresholds that are outlined in the American Academy of Pediatrics guidelines can, generally speaking, be used. In the previous episode, Paul, we spoke about how these babies need early screening, and that's part of the AAP guidelines. When you have an infant born to an alloimmunized mom, you need to screen them early. Then I would recommend using the thresholds outlined in the American Academy of Pediatrics hyperbilirubinemia guidelines, knowing that they're also on the lower line, the
Mhm.
lower threshold for treatment, because if the DAT is positive and they have HDFN. And so we treat them. I would also say once you consult with your neighborhood neonatologist, or if you're in doubt, it's okay to start phototherapy and then figure out the details if you're concerned that this baby is severely affected.
What about a baby who's moderately affected? How do you deal then with things like moderate anemia?
Is it okay if I talk moderate hyperbilirubinemia and
Yes,
anemia?
yes, yes, yes.
Yeah. So the good thing about the new AAP guidelines is I believe that curve goes all the way to 0 hours of age.
Well, that's
The
helpful.
Yes, yep. And the Butani curves, the risk stratification curves did not. So if you can use those just fine.
But they're
And
extrapolated, right?
they are, but I think they are a good guideline to guide your phototherapy. So does every infant born to a mother who's alloimmunized need to be started on phototherapy at 0 hours of life? No. You can check a bilirubin at birth and determine if they need to be started on phototherapy. The caveat to that is if we already know they're severely affected, we go ahead and just start them. But get those labs back quick, follow the AAP guidelines, and then depending on, how high it is, at birth will give you an indication on how quickly you need to check. Oftentimes, a good rule of thumb is every 6 hours, but in a baby that's got a really high bilirubin at birth, you may be checking even more frequently than 6 hours.
Talk to me about late onset anemia. Why does that happen?
Yeah, HDFN is a very interesting disease. The two things that we watch the closest, or the two results of the disease, are hyperbilirubinemia and anemia, as we've talked about that. Infants and fetuses can have early anemia and they can have late anemia. And early anemia probably also includes fetal anemia. Okay. Now, if a baby is born with a normal or a not transfusible hemoglobin, I have babies with HDFN that are born with a hemoglobin of 17. If they're born with a hemoglobin of 17, they do not have the early anemia of HDFN, or at least it's not severe. Okay. But that doesn't mean they're not at risk for developing anemia later. And that's what we call the late anemia of HDFN. There's debate on what the actual definition is. So they're at risk for developing anemia for weeks and sometimes months, depending on the severity of disease. And when I say anemia, anemia requiring transfusion. So from the anemia aspect, we check at birth. The recommendation in our guidelines is that we continue to check at least weekly until their hemoglobin has stabilized. And we need to make sure that that baby has 2 consecutive hemoglobins that show that they're not continuing to get anemic before they're out of the clear. And unfortunately, this is a rare disease, or fortunately, it is a rare disease. Unfortunately, we see missed cases of HDFN where an infant has great parents who at 4 weeks or 5 weeks of age say, my kid is very pale and they're starting to slow down. And we bring them in and they have a hemoglobin of 6. And that is the late anemia of HDFN. Or I've seen 4 and even lower.
Oh
And
my.
so, yep, that's why you have to continue to surveil for the late anemia of HDFN in the affected infant, even after discharge. And like I said, we recommend that the pediatrician continue to check weekly after discharge, and till we see at least 2 that show stability or an increasing hemoglobin.
And which population should I be doing that for?
Yeah. Our recommendation is that an infant born to an alloimmunized mother with a positive DAT, direct Coombs test, is an infant that I would consider to have HDFN. I can't tell you based on the Coombs test binary. I can't tell you whether it's severe or mild. And
Mhm.
all of those babies, after they're discharged home, if they're mild, they're probably going to go home pretty early if they're term. All those babies should have at least 2 hemoglobin checks, 1 week apart. Sooner if needed, but at least 1 week apart. If it continues to drop, which may even be physiologic. Just keep checking every week to keep them safe.
Okay. So talk to me about the latest recommendations. What's changed and what's important to know?
Yeah, I think it's important to give you a little background on the recommendations. So these are not recommendations that were initiated by the Committee on the Fetus and Newborn of the AAP. There were some stakeholders, including hematologists, transfusion professionals, transfusion docs, obstetricians or MFM specialists, trauma docs, and pediatricians, and even parents, part of foundations. These are all stakeholders that came together and said, we need guidelines. There are no national guidelines to guide the care in pregnancy and after birth for infants and fetuses with HDFN and the mothers who are alloimmunized. So there were some great leaders that were able to put this, what we called a consensus conference together, where we used fancy methods called the Delphi method to vote on guidelines. So we actually started with, systematic review and meta-analysis that was funded by a couple of entities, including the Department of Defense, actually,
Oh,
was one
wow.
of the funders. Yeah. And funded the studies that went into systematic review and meta-analysis. We met together as a group. Well, actually, over a year, we drafted guidelines, and this all happened between 2024 and 2025, maybe late 2023. Then we met together in a conference in the spring of 2025, and we voted on these guidelines in an iterative fashion. That's the Delphi method, and established expert consensus guidelines that are hopefully backed by as much evidence as possible. So this guideline will result in 3 papers that will be published. There's one from the trauma group, and that includes sort of the blood transfusion group. There's one paper from the obstetric group, and there's one from the pediatric group, and I was a part of the pediatric group. The MFM paper's been accepted. We hope the pediatric paper will be accepted soon. So this is a guideline that you can look for, hopefully appearing online, and I'll certainly pass it on to the podcast when it's online.
Oh, thanks.
Yeah, we hope early 2026, maybe even spring 2026 is a guideline. Sorry for the long-winded answer.
No, that's very helpful. That's an unusual approach, isn't it? But a laudable one, right? Because the people who needed an answer got together and figured out an answer.
Yeah. When we're seeking endorsement from the American Academy of Pediatrics, and there is a chance it'll be published in the journal, the official journal of the AAP, the pediatrics. So that's where the guidelines come from.
I suspect it's a difficult guideline to describe verbally, but can you tell us the high points?
Absolutely. The first recommendation we talk about is risk stratification. So the recommendation is, we talked briefly, I think in the last episode, about high risk pregnancies. So an alloimmunized mother giving birth to a baby, if that alloimmunized mother is alloimmunized against KEL at a titer level of 4, or is alloimmunized against any other antigen with a titer level of 16 or greater, we recommend that those deliveries are planned to occur at a place with a level 3 or a level 4 NICU. And so, like we sort of spoke about, first point is risk stratification, making sure that we're prepared for this infant. A couple other high points, we recommend obtaining, these studies, total serum bilirubin, the DAT, CBC with retic at birth, and if possible from the cord blood. There's some evidence, especially in the preterm infant, to show that results in better outcomes. We talk about IVIG and the uncertainty around IVIG. We recommend against iron supplementation because this is not a hemorrhagic anemia. This is a hemolytic anemia. We touch on breastfeeding, which we tend to think is okay in these infants, even though there is a chance of some amount of antibody crossing, being introduced in the enteral tract of the infant. But there's not evidence to suggest that the effect of breastfeeding in the case of an alloimmunized mother in an infant with HDFN is severe.
Is that IgA antibody then?
It is, correctly. Yep. That is the antibody that's transferred in the breast milk. We talk about a little bit of transfusion guidelines, and then follow-up, like we sort of pointed to, and then pediatric hematology follow-up is another thing that we touch on. The importance of it and sort of the cases when that might be indicated. Perhaps not every baby, but if they're at risk of needing a transfusion. And that's the good thing about the guidelines, is they have a lot of the details in there.
That's terrific. We hope to be able to look at them soon, but it sounds like in some ways it quantifies expectations as much as anything. It gives you actual guidelines as opposed to principles.
Yep. Yeah. Yep. I think the best thing we have from the AAP right now is the hyperbilirubinemia guidelines.
Uh-huh.
It helps with the hyperbilirubinemia. It doesn't touch on anemia, doesn't touch on risk stratification, certainly doesn't touch on transfusion and other things like that.
Gotcha. What do we know about the long-term outlook for infants treated for hemolytic disease?
I'd say in the cases where they receive good prenatal care and that prenatal care is successful, and sometimes that does require intrauterine fetal transfusions and other therapies that we have to provide. But in almost all cases, we can make sure that these infants are born alive. And in almost all cases, if we are on top and take a very proactive approach to treatment, we can make sure that these babies have great outcomes. I'm almost convinced that if we do the things that we've outlined in these guidelines, that you can almost always avoid exchange transfusion. That may not be 100%, but pretty dang close. Yeah. If you are on top of these, the exchange transfusions tend to be required when we miss the boat and we check the first billy at 6 or 12 hours or something like that.
Fascinating.
I always tell parents, Paul, that the good thing about this disease, if there is any good thing, or perhaps the less bad thing about this disease, is it's time limited. And so the half-life of human antibodies are around 4 to 6 weeks. And depending on the antibody load that the baby received, once that cord is cut, it's only a matter of time that it wears out. And so we sent, even this week, I sent a baby home on home phototherapy due to all immunization. And I told the parents, I'm not sure when, but this is not the norm forever. This will burn out, those antibodies will go away, and it'll be okay.
And it's representative of the beautiful thing about so much of what we do in pediatrics is that little things can make a difference for an entire lifetime.
Absolutely. Yep. The great thing about being a pediatrician is that we set them up for success, right? And
absolutely.
Yeah.
What can you tell me about what the future may hold with therapies and interventions for HDFN?
There's a lot of great people and great groups around the world that are working on therapies and the understanding of HDFN and alloimmunization. And so I could highlight a couple of those. I would say we've come a really far way with our ability to do intrauterine fetal transfusion. There is a role for IVIG therapy in pregnancy. We're still not totally sure about the neonatal period, perhaps not, but those moms can receive those therapies. One of the most exciting ones that I'm excited about is in pregnancy. We have a monoclonal antibody called nipocalimab that is a monoclonal antibody that can essentially block the transit of harmful immunoglobulin G, IgG, across the placenta. And so it's in phase 3 trial right now. And this drug, although it has to be administered on a weekly basis during pregnancy from starting at about 10 to 16 weeks, it looks like it may be a promising way to avoid intrauterine fetal transfusion and fetal demise in these moms. And so you're like, what? Why would we administer an expensive drug weekly, for 20 to 30 weeks of pregnancy? And the reason why is because you talk to the moms who have carried babies who have the severe disease, and they've gone through fetal loss, and they've also experienced multiple intrauterine fetal transfusions, and those are no fun and they're very expensive. And so we hope that there are drugs on the horizon that can help prevent these diseases and save these babies from morbidity and mortality.
And are these monoclonal antibodies directed against particular antibodies? So would there be like a KEL monoclonal antibody?
Yeah, no, they actually are directed towards what's called the FcRn receptor, which we in newborn medicine take pride in saying that it was discovered first in the placenta. It's the receptor that is part of the signaling and actually the transit sort of pathway of antibodies across the placenta. And so this monoclonal antibody actually targets the receptor, and if it overwhelms the receptor, you actually take more of the nipocalimab drug across the placenta as opposed to the harmful pathogens. Truth be told, it also inhibits the transit of good antibodies across the placenta. But so far, the data suggests that the moms and the infants and the fetuses do well from a good immune standpoint.
Gotcha. Where are the big gaps in our knowledge?
There's a lot. And I guess anytime you do research in any area, you realize we got a lot of big gaps.
Sure.
Even our ability to predict severity based on our lab tests is poor. And we have to do a lot of screening. One thing you can look up is the way that we screen fetuses for anemia is by doing frequent ultrasounds and measuring the middle cerebral artery peak systolic velocity in the fetus to screen for anemia. And that's just a really fancy ultrasound technique to try to detect anemia. But the reason why we have to screen so many moms is because we're really bad at predicting which ones are going to need intervention or not, and we don't want to miss it in case they do need intervention.
Right.
And likewise, our ability to predict which infants are going to be the most severely affected is sometimes I gave you those sort of criteria for high risk, but they're far from perfect, and we have a hard time predicting who's actually going to be severe and need intervention.
But we're also trying to set ourselves up with an abundance of caution in the meantime.
Yep, that's what we do until we get better information.
Perfect. Well, this has been very helpful, Tim. I feel like I understand some things that I've hoped to understand for a long time. I really appreciate you doing such a great job of teaching about a complicated topic. I'm sure there will be more. First of all, is there anything else you think we ought to mention about this?
No, I think we hit it pretty well, Paul. I'd say one thing we're trying to do is spread awareness. Back in the day, pre-ROGAM, this is something that pediatricians, neonatologists, and obstetricians dealt with all the time. These are the stories of the Rh negative mom that was only told she could have 2 pregnancies because her partner was an Rh positive dad. Because the frequency has gone down, sometimes our awareness and our education regarding the disease also goes down, which is a great thing, but it's an unintended consequence of that. And so I think one of the foundations I work with called the Allo Hope, ALLO Hope Foundation, they provide a lot of information. And, a lot of the resources we have out there is a good way to just continue to educate yourself about this disease. Even though it's rare, I think it's an important one for pediatricians, newborn providers, neonatologists to understand.
As I think we learn over and over on this podcast, what we hope to do is understand the right triggers and the right questions, and then have the right people to collaborate with to do the best thing.
Absolutely. I'm a big believer that I want every newborn in the world, but sometimes I say in the state of Utah, I don't care where you're born. I want you to have a good life. And so if anybody ever wants to give me a call or an email, they're always welcome to, and I'm happy to take on that. And like you said, Paul, pediatrics is a practice of collaboration, of helping each other out.
Yep. Well, thanks so much, Tim. I'm sure there are questions. Please send your questions to questions@vcurb.com, and we'll address those next week. There's still so much to learn. But in the meantime, we'll look forward to talking to you again Christmas 3 years from now. And thanks to Elisa Stoddard for making this all come together. And thanks to Janice for listening. We'll see you next week.
Thanks, Paul.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.